that was performed, that he should have seen it. He didn't know why he didn't see it, but that it was below the standard of care for him not to see it. So the liability issue was off the table, but this is what happened to Clint Morway. At age 39, Clint began having headaches, and he went to his primary care doctor, who sent him over to the hospital for a CAT scan. The CAT scan is read as he has sinusitis, and oh, by the way, I see something in his cerebellum. I'm not sure what it is. I think he needs an MRI and an MRA. So the next day, Clint goes to the hospital to have his MRI and MRA. The MRI and MRA are read by a different radiologist. This radiologist does not take the earlier CT scan and the report out of the envelope, the same envelope that has the requisition in it for him to have the MRI and MRA. He doesn't take it out and look at it. He doesn't look back in the computer to see what it was and what the reading was on it. But he reads the MRI and MRA as being negative, except for the fact that Clint has sinusitis. So Clint is sent back home with treatment for antibiotics for sinusitis, and over the next 3 weeks, he follows up with his primary care doctor. One afternoon, Becky gets a call at work from Clint, crying, "My head, my head." Becky tells him to call the ambulance and she'll meet him at the hospital. Becky gets to the hospital, Clint grabs her hand and says, "I love you, where's my mom?" Clint's mom shows up at the hospital. They perform a number of tests, including a lumbar puncture, and what they find is that the aneurysm that was present on the MRA 3 weeks earlier is leaking. And in between Clint being seen there in the emergency room, having his lumbar puncture, and being transferred to Dartmouth, the aneurysm ruptures. For the next 6 months, Becky and her children, they have 3 children who at the time are ages 8, 10, and 12, sorry. They want to believe the doctors who tell them that they think that they hopped on things quickly enough so that Clint's going to be able to recover. Unfortunately, that is not so. Clint has never recovered. And today he lives at a small brain injury home in Jeffersonville where there's 13 patients. He is quadriplegic. He has no means of communication whatsoever. He's trapped inside his body. And this leaves Becky with 3 children. 3 children who basically became a mess over this. Her daughter tried to run away from home. Her middle son tried to hurt himself. And her youngest son knew that he had a father once, but he doesn't have one anymore. And although they make frequent trips to see Clint, he needs so much care that he really can't be taken out of the home much at all. So he needs 24-hour care. This has blown this family to bits. And I bring this up because it is an example where negligence does occur, even though nobody wanted it to occur. As a result, Clint needs care for the rest of his life. And other than this aneurysm, everybody agreed that Clint had no other health issues. Therefore, the rest of Clint's life is likely to be a very long time. He has pretty much a normal life expectancy. And I feel inadequate being here to try to express to you what this family has gone through, what they continue to go through. And I'm really sorry that Becky couldn't be here today so that you could put a face to the story. But I feel like it is important for you to understand that there are these unfortunate circumstances out there. No matter how much we might wish that they didn't happen, they do occur. It's not often, but they do occur. And these people's needs and rights need to be addressed as well.
Before you stand up, Chris, did you? I was ready to
Okay,
tag
all
in
right, all right.
as the next person. That's okay.
Go for it, yeah.
Okay. Hi, I'm Chris Maley, and I'm an attorney in Burlington as well, and I represent patients in medical malpractice cases. Sorry.
Okay.
I used to practice in Boston, and I was there for about 6 years, and there I represented doctors and nurses and hospitals that were affiliated with Harvard. So I have a little different perspective too. I've been on both sides of these claims, and it about splits my career. I've been doing this close to 15 years. And now, back in Burlington, I'm exclusively representing patients. I appreciate the opportunity to be heard. I'd like to thank the committee for the time. The reason we brought up that story is that we just don't want victims lost in the discussion. We want to put a face to what restrictions on patients' rights might look like. And I know under consideration is the no-fault system. And I've looked at the New Zealand no-fault system, and I've read Dr. Shao's materials, and I've actually responded to his materials in writing, and I have the letter that I wrote that I'm happy to provide to the committee, and the materials that went with it, which are pretty extensive. I could give anyone who is looking for it. I'd like to be a resource going forward. What I really want to make sure that everyone understands is the trial lawyers aren't here to say we want to stand in the way of moving forward with healthcare reform. I think that healthcare is a right, not a privilege. I think what you all are aiming to do is a moral and economic decision that makes a lot of sense. I'm with the governor. We want to help. We want to be partners. We want to try to find ways to cut costs anywhere. And if that means looking at the medical malpractice system, we're happy to do it. So I've looked at Dr. Shao's no-fault proposal, and the worry that we have is that people like Clint will be left out of that equation. What the no-fault system does is it severely limits the amount of compensation that victims get. There's a lot of talk about it brings more people into the system, and that has moral appeal to it, but what it really does is take from catastrophically injured victims and shares the wealth with folks that don't have those serious injuries, that are not in the system now. Generally, the people that are in the system now are folks that have permanent harm, catastrophic harm, loss of limb, blindness, pain for life, brain injury. Those types of folks that can't care for their families, can't care for themselves, and are not able to work or be productive in society. Those are the folks that generally end up with malpractice claims. And what a no-fault system would do is bring in all folks that aren't typically in the system. And I think that would be something that the state simply couldn't afford. You're now compensating tenfold what you did before, and you're now looking at a system that is dealing with patients that maybe are able to get on with their lives. And I don't mean that to be dismissive. I just mean that in terms of priorities, in the clients that I deal with, we try to take the people like Clint and say, these are the people that need to be taken care of first. And so the concerns I have, and I've expressed to Dr. Shao through the letter, and I will give that to you, is that this no-fault system in New Zealand is set up in a world where there's a social structure that's very different than Vermont. It's like a Scandinavian country where they have very high tax rates, and they have very, very wide safety net, much more progressive and wide than Vermont has. And so when they say in the New Zealand system you're able to get a lump sum payment of up to $70,000 for someone like Clint, a maximum, no matter how egregious the error, no matter how severe the problem for permanent impairment, they can afford to do that because folks are taken care of in New Zealand in a way that they aren't taken care of in the United States. The average payment in the New Zealand system, and I know you're not jumping off a cliff to the New Zealand system, but this is what Dr. Shao has suggested. The average payment in that system is $30,000. And it's funded by taxpayer money, income tax. And my question that people may want to consider is who is going to pay for the bureaucracy for this no-fault system? Is it going to be, as Dr. Shao suggests, insurance companies, like medical malpractice insurance companies, they're going to assume the burden of the administration and the compensation? Or is it going to be the state? And if you're talking about the state, you're shifting a lot of dollars that are now private into a state system. I pay the cost for the administration of malpractice cases now. I hire the neurosurgeon from Mass General at $800 an hour. I do the work. ProSelect and Medical Mutual of Maine do the same on the other side. Now you're taking a system that basically to get to the mediation, and that's where 90% of the cases resolve, you're taking these private dollars and saying, okay, now that battle is going to be on the state, I suppose, or just on the insurance companies. And there will be a battle in a no-fault system. In the New Zealand system, only 40% of the people that apply get compensation, so 60% of the folks don't. And the reason of that is that the causation analysis, that is, whether an injury is treatment related, whether it was unavoidable, or whether it's due to a treatment decision by a doctor, is incredibly complex. It's one that's done through expert testimony, peer-reviewed medical journal articles, competition about both sides, cross-examination, and that battle won't go away in a no-fault system. The victim will have to go forward and prove to the panel or whoever these independent folks are that their treatment caused their harm. Not that it was just a bad thing that happened. There was some type of connection to hospitalization or to a doctor's decision that made them have this bad outcome. So it has a tinge or an element almost of fault or attributing conduct to what happened. And that can't really be removed. There are some things that just happen that are bad outcomes that are not due to a doctor doing anything wrong. I spend 99% of my time reviewing and rejecting cases. And the vast majority of them I say, I'm sorry, something really, really bad happened to you, but I don't believe that it was the doctor's fault that you ended up in this situation. It's a bad thing that happened. So these cases that are screened out now by attorneys like me now end up in this system. So I just think the no-fault proposition, the idea that you're bringing more compensation to more people, has some moral appeal to it, and we're willing to work with you and talk to you about why we have concerns about it. But I don't think we should just jump to going right to that law. I mean, we were okay with H202. The administration said, let's study it. We'd like to study it. We'll study any proposal that will cut costs and get you to where you need to do. We're open-minded to that. But to just say, now the administration has to give the system, no-fault system, back to the legislature in a year, I think is a leap from idea of looking at things very, very closely, looking at the data, look at the experience in New Zealand, look at the limited experience we have in the United States. There's been a couple systems that have been set up. One was the vaccination program, where there was immunity for injuries related to vaccinations, and that has been a disaster. I read a statistic that 75% of people didn't get any compensation after 7 years of legal battles. There's a Virginia system that was set up for neurologically injured infants. It's broke. It hasn't compensated people the way it was supposed to. So we can look at all these things, and we'd like to do that, and we'd like to be partners in that. And hopefully there will be the discussion about studying ways to make the system better than what it is. I'm sure there's ways that the malpractice system can be improved. Some of the thoughts that I have are sort of working themselves into the system now. The vast majority of claims resolve at mediation. Very, very few cases go to trial. What happens is there's an exchange of information for a long period of time, depositions of experts, and a lot of expense on both sides, and we get to a mediation. Experienced attorney or judge says, here's the strengths of the case, here's the weaknesses of the case, and here's why I think you should move this way, here's why I think you should move that way. And in that process, what often happens is there's a human interaction between doctor and patient that is not part of a trial. You get, I'm sorry. You get, here's how the protocols have been changed. Here's how this will never happen again. You get tears. You get a side to it that really isn't all about dollars anymore. It's about preventing it from happening again. And that works. And what I've tried to suggest to Fletcher Allen and to others is, let's do that earlier. Let's do that pre-suit. I have my experts. I'll give you time to have your experts look at this. Let's sit down before even jumping off the cliff of litigation. And it's worked a couple times. It doesn't happen very often, and I'd like it to happen more. We get to a table and we hash it out, and the case is resolved. And it takes away 2 or 3 years of process and a lot of money and a lot of heartache on both sides. I mean, I'm not going to make light of the idea of a physician being sued. It's very, very difficult for them. And they take it very personally. When I represented them, I saw that firsthand. But there are ways that we can improve things. And one of the things I think is sort of a buzzword that we hear about and that I'd like to talk about a little bit, Dr. Shao focuses on, is the concept of defensive medicine. And are doctors in Vermont afraid of being sued? I'm sure they are. I can't speak for the psychology of the doctors in Vermont, but when I represented them, I knew they didn't like the idea. But is that fear based upon the litigation experience in Vermont and the way Vermont is set up in terms of claims? I don't believe it is. We are, as of 2006, the most recent data I could get, we were ranked 51st in the country in terms of median payouts, meaning we're the smallest malpractice state in the country in terms of what victims get, and in terms of the amount of claims. It's, even though the majority of states have some type of serious tort restrictions, it's more difficult for patients here than anywhere else in the country statistically to get recovery. So that reality, I think that is maybe lost on physicians. And if they are afraid of certain kinds of claims, I would love to have some type of interaction and some type of education to be able to say, this doesn't happen. You're not going to get sued for this. It hasn't happened. There was a recent article that came out about orthopedic surgeons, and they're ordering MRIs and CT scans for defensive purposes. There was a survey done. It's been widely criticized, but there was a survey done that talked about the percentage of studies that they did which were not for the benefit of the patient, but were for the benefit of the physician to cover themselves for liability concerns. Really high numbers, and so it got a lot of attention. I read that article and I said, I don't know of an instance where an orthopedic surgeon in Vermont has been sued for failure to order MRI or CT. So I sent an email out to our organization and I said, has anybody, and I'm not limiting it to time, has anybody sued an orthopedic surgeon under the circumstances that are in this Philadelphia or Pennsylvania study? And I got no responses. And I can't remember from doing my defense work that existing either. So there is an element of boogeyman, that there's this lawsuit thing that's going to happen that doesn't. And another thing about the defensive medicine that needs to be addressed is the statistics and data we have on it, Dr. Shao admits, are very, very shaky. They're unreliable. The main study he focuses on is a Harvard study, and I can get anyone that study who'd like. But she says the quality of evidence is very low on the extent of defensive medicine. I don't think we have any Vermont-specific data, but nationwide, the data is very, very unreliable, and that's, Dr. Shao says, notoriously difficult to quantify. So to just say that we're going to do this, take away patients' rights to court, and that you're immediately going to remove defensive medicine, I don't know that that can be a leap that has been established so far. One of the things that has been shown by experience, and we can look at other states with defensive medicine, is that tort restrictions, severe tort restrictions, do not necessarily reduce defensive medicine. Texas, there's next to no lawsuits because their laws are so difficult for patients. The cost of health care there is among the most expensive in the country. Medicare reimbursements are up, I think, 16% over the national average, as compared to other states that don't, have their restrictions. Michigan, California, some of the states that have really, really tough tort laws, their utilization is not down. So if there was this rampant defensive medicine that was occurring, you would assume that if doctors had less a threat of being sued, that there'd be less utilization. But the data is actually otherwise. So I think we could learn from what some of the other states have looked at in terms of the extent of defensive medicine, the way to reduce it, and I hope there's a way that if it's there in Vermont that we can address it, and if we can address it through education of doctors or through some part of the medical malpractice system, that would be a good thing. If there are savings to be had, we're open to them. But I just think we need to take a look at defensive medicine and understand where some of the data comes from. I'm sorry.